لكن الرايت renal vein directly go to the inferior vena cava. The left renal vein it drains the left suprarenal vein, and it drains also the left renal vein. The left renal vein is longer than the shorter right. This is why the left kidney is more suitable for renal transplant, because it has a longer renal vein. This is concerning the vasculature of the kidney. The kidney is covered by layers. This is the fibrous capsule, and this the perinephric fats around it. And then the facial capsule, which contain the suprarenal gland. And after that, the paranephric fat. This is the four. This fat is important for support the kidney. If loss of this fat, the kidney will be more mobile, and this will lead to killing of the urethra and can reduce the renal column. Concerning the applied anatomy of the kidney, which is the most important thing in this area. Number one, the renal vein. If there is disease in the kidney, this will lead to stretch of the capsule. The stretch of the capsule of the kidney will produce the renal vein. The renal vein characteristically dull, aching vein is not sharp, present in the loin, and from the loin bottom to the hypochondrium of the same side, and to the suprapubic region. This area is supplied by thoracic 12. This is why the distribution is vein here. And also, it is important that it is not aching. From one to the never reach the other side, never reach the genitalia. Number two, if this is the posterior surface, this is the spine, and there is the sacrospinalis muscle, and this is the last rib. The angle between the last rib, rib 12, and sacrospinalis muscle is called the renal angle. This renal angle is important if I find swelling in the renal angle. Renal angle is swollen, especially tender. Especially the patient complain of fever and rigor. This is diagnostic for the perinephric abscess. And this perinephric abscess lies around the kidney. So there is no urinary manifestation. No urinary manifestation at all. No dysuria, no frequency, no renal pain, whatever this. But the whole landmark is swollen renal angle. Concerning the tumors of the kidney, especially the tumor of the kidney, the hypernephroma, or carcinoma of the kidney. Carcinoma of the kidney produce also certain characteristics. The age of the patient. Also, this age of the patient above 40. Number two, also the patient بيشتكي من hematuria. Characteristic لهذه الهيماتوريا total hematuria, painless hematuria, causeless hematuria, and recurrent hematuria. This is characteristic of hematuria of a malignancy. Also, malignancy of the left kidney can obstruct the left renal vein and can produce varicocele. Reason, if I find reason for progressive varicocele, I should examine the left kidney for this also. This concerns the examination of the urine. In this patient, I'll find the blood. I found also malignant cells indicating the tumor of the kidney. The renal transplant, you know the renal transplant. Usually the left kidney is preferred to be used for renal transplant because has a longer renal vein. However, if this kidney contains an aberrant renal artery supplying it, aberrant renal artery supplying it, and this is the kidney is the most suitable part of the kidney for transplant because of this long renal vein. But if I find aberrant renal artery, I have to occlude it. So part of the kidney is going to die, so it is not suitable for transplant. I have to change it. I can use the right kidney. And you know, for renal transplant, the area of transplant is the area fossa in front of the iliacus muscle, and the renal artery is anastomosed end by end to the interior iliac artery, while the renal vein is anastomosed end to side to the external iliac vein, and the ureter is anastomosed to the bladder. And the ureter is the most difficult part in renal transplant, and 80% of failure of renal transplant is due to manipulation of the ureter or failure of anastomosis of the ureter. Despite far concealing the important parts in the kidney, stone kidney, usually stone kidney has a large size. This is the calyces, and this is the pelvis of the kidney, and this is the ureter. Usually the stone kidney becomes enlarged and becomes stuck hole. And this stuck hole stone does not produce renal colic, but it can produce renal pain, which is a dark aching pain, because this stone will never pass into the ureter. But small kidney stones can travel to the ureter and produce this severe pain when enter the ureter. A stuck hole stone is silent or produce dark aching pain. Concerning the ureter, this is the left kidney, and this is the pelvis of the kidney. This is the ureter, and the ureter enters the pelvis, pass towards the ischial spine, and then pass forward and medially into the superior medial surface of the urinary bladder. The ureter is 10 inches by the esophagus, half of it in the abdomen and half of it in the pelvis. It has 5 constrictions. The pelvic junction is the first one, and when it enters the pelvis, the second one, and towards the ischial spine, this is the third one, and at its entrance into the bladder, and at its end into the bladder. At this such position, the stone can be arrested at there. This is important. If I find an oblong radiovate shadow near to the ischial spine in the pelvic vein, this is a pelvic stone. Also, if I find at its entrance into the pelvis, it crosses the common iliac artery, the bifurcation of the common iliac artery in front of the sacroiliac joint. If I find an oblong mass, radiovate, in front of the sacroiliac joint, oblong, it is stone in the ureter. Also, posterior of the ureter is important, because I find the posterior is the psoas major muscle, lies posterior to the ureter. And this psoas major muscle separates the ureter from the transversal processes of all lumbar vertebrae. This is an important relation. The psoas major muscle separates the ureter from the transversal processes of all. If I find an oblong stone at the tip of the transversal processes, this is the iliac stone, because there is a passes in front of the tips of all lumbar vertebrae. This is important posterior relation. This posterior relation is important because, number one, this is the psoas major muscle. The psoas major muscle in front of it passes the genitofemoral nerve. Genitofemoral nerve from L1 and L2. This genitofemoral nerve divides into 2 parts. One part is the femoral branch, and the other is the genital branch. The genital branch it passes in the spermatic cord to supply the cremasteric muscle and supply the covering of the cord. Sensory nerve supplies the covering, and the tunica vaginalis that cover the testis. Or the femoral branch of the genitofemoral nerve supplies part of the skin at the upper part of the side. This then the ureter passes crossing it. So during pre-stances, during fistone, irritation of this nerve, this is why the pain radiates to the external genitalia, radiates to the testis. And this is why the pain radiates to the inner aspect of the side, along with the distribution of the genitofemoral nerve. Concerning the anterior relation of the ureter, it is important to know that the anterior relation in male or female is the gonadal vessels, the sacral artery in male or ovarian artery in the female. It passes in front of the ureter. No need for other relation for this ureter. The blood supplies the ureter from the renal artery, upper end, from abdominal aorta, from the common iliac artery, and from the superior and the inferior vesical artery, so has multiple segmental blood supply. This gives the ureter the ability to be mobilized, because if this is the ureter, this blood vessel form a network in the adventitia of the ureter and rich plexus. This is why I can manipulate the ureter, can transfer it to another side. If this adventitia is injured, injury to the ureter will occur. So this is concerning the blood supply. Concerning if there is a stone in the ureter, I can define it into three areas. The upper part of the ureter, there is a stone in the upper part of the ureter, stone in the lower part of the ureter, and the stone in the intramural part of the ureter. Stones from upper third will give the renal colic. And renal colic is severe pain, severe or agonizing pain. The patient rolls out, يلف حوالين نفسه from this pain, ومعاه vomiting ونيوزيا. هذا البين جاي من اللوين to the right hypochondria, to the groin, and radiate to the external genitalia, or the inner aspect of the side. This is typical for renal colic in the upper part. In the lower part of the ureter, all this will occur, plus they lead to the external genitalia, or plus the inner aspect of the side more. If this intramural part of the whole, this intramural part, this renal colic is also okay from loin to the groin, to the external genitalia, to inner aspect of the side, and also to the tip of the penis. The tip of the penis, and we will have strangling. Strangling means hesitation. This patient has a tense desire to urinate and then go to the toilet and do nothing and return again. This is strangling, characteristic of the stone in the intramural part of the urine. The pain is severe, and this is the distribution of pain. So upper third or middle third. Upper third usually does not go to the surgery tank or any aspect of the side. But in the lower part, I want the surgery tank, the inner aspect of the side. The intramural part, I want the whole long tip of the penis and also strangling will occur. This is how can I differentiate different types of hematuria.